Thank you, Cynthia, for the very kind introduction. Good morning to everyone who is listening. Um, Before I start, I would really like to acknowledge and thank all the work that the HealthTree Foundation is doing for multiple myeloma and beyond. I think that in terms of education, dissemination, and really bringing all the news, updates, answering questions, doubts, I think that it is a very important, tremendous effort that I've been witnessing throughout the recent years, and I couldn't be happier participating today at this in this webinar. With this said, I will start sharing my screen. Um, and this will be approximately 20-25 minutes, 30 maximum presentation. And I'll try to make it as um, practical as possible about the possibility of monitoring treatment efficacy and detecting residual disease in the peripheral blood. And because it's blood and not marrow, as usual, we decided a few years ago that to separate both and to make it easier to know when we are talking about residual disease in the marrow or in the blood, that whenever it was in the blood, we would call it as peripheral residual disease or PRD, whereas in the marrow, it is as usual MRD. These are my disclosures. Um, and before I start out with some more content, I would like to provide three statements, three very practical statements. Uh, One is that risk assessment of patients with myeloma is, as it should be, routine, mandatory in patient management. It couldn't be any other way. The patient needs to be characterized very, very thoroughly, having all possible information to make the best possible decisions. I think this is something that everyone would agree. The second point is that not all tests that we perform while characterizing a patient with myeloma are necessarily attached with a treatment decision. Some may be, many others are not. For example, beta-2 microglobulin, even cytogenetic alterations, electrophoresis. These are very important, paramount, but aren't always associated with a treatment decision. And the reason I'm saying this is because I do not agree with the argument that I do not perform MRD because it will not change treatment. It may change, it may not. But the reason why we perform MRD is not necessarily to change treatment, is to have the best possible characterization of a patient with multiple myeloma. In this case, a marker of treatment efficacy.
I apologize, Dr. Paiva. We've got some information saying that your audio is a little bit wavering. Could you come a little closer to your microphone?
Yeah, and I'll speak a little bit louder also.
Thank you so much.
So why MRD and why is MRD so important? I think that nowadays it has become consensus that MRD is one of the most important, if not the most important prognostic factor in myeloma. And I believe that the reason is well illustrated in this slide. And the reason is because with a single snapshot of MRD assessment, we are collecting all this information, the patient comorbidities, frailty, staging, the extent of disease dissemination, tumor biology in terms of sensitivity or resistance to treatment, also the adhesion to treatment, the toxicity, which may lead to dose adjustment or drug discontinuation, and ultimately the efficacy of treatment. All these components are embedded in a single assessment of MRD. And this is why MRD is such a powerful prognostic factor in myeloma. In fact, I think myeloma is a paradigm that really shows how the efficacy of new regimens, deeper and durable MRD responses, and prolonged survival are interconnected. We have seen how, throughout the last 5 to 6 decades, the overall survival of patients with myeloma has progressively increased, and so have increased the rates of MRD negativity. This is interconnected. Despite the fact that we have more and more sensitive methods to assess MRD, despite the increased sensitivity, the MRD negative rates are higher and higher. And this is because of the efficacy of all the new regimens. What about the newer immunotherapies, CAR-Ts and T-cell engagers? Well, the concept of MRD continues to apply also in this treatment setting. Recently, we had the opportunity to show that once again, in patients treated with T-cell redirecting immunotherapy, both CAR T cells and T-cell engagers, progression-free and overall survival are completely different in those patients achieving undetectable MRD when opposed to those in which MRD remains positive. And as you can see, this information is useful both in terms of patients receiving CAR T therapy as well as T-cell engagers. Now, we are witnessing new outcomes in multiple myeloma, and new outcomes need new endpoints. In this slide, there are, I apologize for the references that are inaccurate. This was shown in one meeting in Paris earlier this year by Dr. Peter Sonneveld. And here we are seeing the estimated progression-free survival of patients treated with quadruplet regimens, both younger patients eligible to intensive therapy and the elderly non-eligible to intensive therapy. And as you can see, the estimated progression-free survival with the new regimens is reaching 8 years in the ineligible patients and remarkably 17 years in those that are eligible to transplant. These are really new outcomes. And that because of that, I also think we need new endpoints and new concepts. Here, I'm presenting what is still an hypothetical scenario, but a scenario in which we are working intensively, and hopefully this could be a reality in 5-10 years' time. A scenario of fixed treatment duration, particularly in those patients with sustained undetectable MRD. Because if the median PFS will be of 17 years, this will be a very, very long time until a potential progressive disease. And I think that this is too long for indefinite treatment until a potential disease progression. So what we would like to see in the future is that after treatment initiation, if the patient achieves a negative immunofixation, CR, as well as MRD negativity during the first year, and if this excellent response is confirmed 1 year after and even 2 years after, and thereby we are talking about a sustained MRD negativity for 2 years during the first 3 years of treatment, this is a patient that most likely will have an exceptional outcome. And if there aren't any risk factors of unsustained MRD negative responses, and last year we have identified together with the Italian group some risk factors such as the presence of 2 or more high-risk cytogenetic alterations, an adverse international staging system at diagnosis, also a high percentage of circulating tumor cells at diagnosis. If the patient doesn't have any of these risk factors, then eventually the possibility of stopping treatment. Not necessarily because myeloma is cured, because unfortunately We don't know prospectively if the disease is cured or not. Maybe, but we don't know it. More with the aim of improving quality of life through a very long treatment-free interval. Because if the expectation is that with 3 years of sustained MRD negativity, the patient may be 10 years or more of progression-free, this is a very long treatment-free interval that will improve quality of life because of reduced cumulative toxicity because of treatment. Also, in this scenario, if the patient relapses, the disease is not refractory to the previous regimen owing to this very long treatment-free interval. And even the patient has been exposed to a 4-drug regimen, for example, but this was 10 years ago. And eventually the patient may be sensitive to these drugs, which increases the number of options for the second line and may improve the efficacy of this second line of therapy and therefore achieve an even longer PFS2. And if we consider the possibility of frequent monitoring of the disease and resuming treatment not at the time of clinical relapse, but at the time of MRD resurgence, the second line may be even more effective. And if the first line produces a PFS of 10 years, and the second line produces a PFS of another 5 years, these are already 15 or more years of progression-free survival. And hopefully, this is bringing us closer to curing myeloma or making it a very long chronic disease. Now, if we are able to reach what is currently, I insist, an hypothetical scenario, this implies a very long period in which the patient will undergo continuous monitoring. And like I said, if we are trying to improve the quality of life with a treatment-free interval, we cannot decrease quality of life with multiple bone marrow aspirates for MRD assessment. And this is why we believe that the sequential use of MRD and PRD assays is the next frontier of response assessment in multiple myeloma, and it is, in my opinion, also mandatory to bring to the field to improve patients' quality of life. Fortunately, I think that myeloma is at the forefront of methods for MRD assessment. I will not go into details in sake of time, maybe in another opportunity, just briefly touch upon the fact that we have methods that are more sensitive than electrophoresis, than immunofixation, that are typically used to measure the M component. And these methods can be applied in serum, such as mass spectrometry, to measure the M component with higher sensitivity when compared to immunofixation. We have next generation flow cytometry and sequencing that detect aberrant clonal plasma cells either in the bone marrow as well as in the peripheral blood. And obviously, each method has its own advantages and disadvantages, and one should select one or the other based on these advantages. And we also have imaging techniques such as PET-CT that detect metabolically active cells inside and outside of the bone marrow. And this is very important in a disease like multiple myeloma. Now, this is a study from our group that was reported at the beginning of this year. And in this study, we used one of the techniques that I was showing in the previous slide, next generation flow cytometry, or NGF. This is a technique that has been initially or primarily developed to use in the bone marrow, but we tested it in peripheral blood. And what we showed, and you can see here, is that when we use this technique in patients that were either under maintenance or observation after maintenance, we detected PRD, peripheral residual disease, in approximately 10% of patients. And as you can see in the slide, the detection of PRD was significantly associated with inferior progression-free as well as overall survival. Now, does this mean that we can now use peripheral blood and forget about bone marrow aspirates? Stop performing bone marrow aspirates? The answer is no. The bone marrow is the primary site that myeloma infiltrates and is the most effective and sensitive sample to study the disease. And probably this is something that will never change with time. And the bone marrow is for sure the optimal sample for MRD assessment. What we show in this slide is the presence of 3 patient subgroups. One in whom, using NGF, the same method, the result was negative in the blood and in the marrow. And as you can see in the slide, these patients have very promising outcome. Then we have patients that show residual disease both in the marrow as well as in the peripheral blood. And as you can see, as I alluded before, these patients have inferior outcomes. And then we have another and third patient subgroup with intermediate outcome. And this patient subgroup is defined by a negative result in the blood while positive in the marrow. This means that the blood is not as sensitive in the marrow. And as you can see in the slide, if there is residual disease in the marrow but not in the blood, this will result in inferior progression-free survival when compared to those patients with double negative result. This is why, as I was saying before, blood is not as sensitive in the marrow. But on the other way, let me also emphasize that blood is becoming so informative that even if the patient shows positive residual disease in the marrow, looking at the blood will inform the doctor of whether or not the patient is at risk of progression, let's say, for example, in 2 years' time, if negative in the blood, or by contrast, the risk of progression is much higher in a few months if the patient is positive in the peripheral blood. Now, those results were implying that the method we were using was not sensitive enough in the peripheral blood. Because of that, 6 years ago, we started a new project aiming at increasing the sensitivity of flow cytometry. And the rationale was, if we want to increase the sensitivity of flow cytometry beyond the 10 to the minus 6 threshold, we need to analyze at least 200 million cells in the peripheral blood, which implies approximately a volume of 50 ml of blood. Now, if we want to measure with flow cytometry this very large volume of blood, we need something else. We need to perform an iteration of the method. And ultimately, what we did was to combine 2 methods that are commonly available in the laboratory of the hematology department. And these 2 methods are magnetic enrichment, magnetic separation of plasma cells, something that is routinely done before cytogenetic assessment, and then on a small aliquot of enriched plasma cells that circulate in the blood, we perform NGF. This way, it can be easily done in the routine diagnostic laboratory despite the larger volumes of peripheral blood. I can say that this manuscript was indeed accepted in Blood and published a few weeks ago. Now, in this slide, we are comparing the detection between the new method in blue that we called blood flow and the standard method that is NGF, that is already very sensitive, 10 to the minus 6. But as you can see, there are many patients in whom we only detect residual disease in the blood, PRD, with the new method and not with NGF. And the reason is because with the new method, we are indeed capable of detecting PRD in the 10 to the minus 7 logarithmic range, and even in some patients, we are able to detect at 10 to the minus 8. And this is, I can tell you, unprecedented sensitivity ever achieved across all hematological malignancies. Once again, myeloma is at the forefront of methods to assess treatment efficacy. Again, we showed that using the new method, this is a clear prognostic value. If the patient is negative in the blood, progression-free survival is very promising. Once again, if there is PRD, then progression-free survival is unfortunately significantly inferior. And in a multivariate analysis, we showed that PRD assessment with the new method outperformed PRD assessment with NGF and together with MRD assessment in the marrow, both at independent prognostic value. And as you can see in the slide, the method is informative in patients achieving CR, also in those that do not achieve CR. It is informative independently of staging of diagnosis, and it is informative in both transplant eligible and ineligible patients. Now, because of the higher sensitivity of blood flow compared to NGF in the blood, does this mean that now we can forget about bone marrow aspirates? Unfortunately, the answer is again no. We have improved dramatically the sensitivity, but again, when we compare the new method in the peripheral blood versus NGF in the marrow, you can see that the concordance is very, very high. You can see that there are even a few patients, very few, in whom we detected residual disease in the blood before we detected in the marrow, but there are still 21% of patients in whom disease was only detected in the marrow. And then we ask the question, what were the reasons behind this false negative result in the peripheral blood? And these are the main reasons, and to some extent, these are correlated. The fact that the patient was undergoing intensive treatment, because of that, very low MRD in the marrow, and because of the treatment also reduces cellularity in the peripheral blood. Now, after seeing this, we have decided to focus our efforts of delivering tools and strategies for monitoring the patients in the blood only during maintenance or observation if the patient is not being treated until disease progression. So nowadays, this is the only setting in which we are performing PRD assessment. And as you have seen in the previous slide, despite the higher sensitivity of blood flow, it was still not sensitive enough compared to the marrow. So our strategy is not only to focus in a specific disease setting, but also in looking for complementarity between blood flow and other methods such as NGS as well as mass spectrometry. And this way we are looking into circulating tumor cells using blood flow, mutations and the B cell receptor using next generation sequencing, and the M component with high sensitive mass spectrometry. In sake of time, I'm only showing this slide in terms of the performance of each of the methods. And very briefly, the two methods that stood out were blood flow and mass spectrometry. Both showed a more balanced negative and positive predictive value. So therefore, we are focusing on these two methods to look for complementarity. And I can tell you that in December at ASH, we will be updating these results in an oral presentation. And I can share with you that the results are very, very promising. What we showed 2 years ago at ASH in 2023 was that by using blood flow and mass spectrometry, therefore blood and serum, if both methods are negative, the risk of progression is very low. By contrast, if the two methods are positive or one is positive, it doesn't matter. If only one or both are positive, then the risk of progression becomes significantly higher. And now, using the two methods, when both are negative, the probability that the bone marrow will be negative is of 84%. This is the highest negative predictive value that we have ever achieved. So therefore, based on these findings, and I can share with you that we are continue investigating very hard to bring what is currently a possible algorithm into reality in the near future. I can tell you that in our hospital, for example, we are testing more and more this potential algorithm, is that during the first 2 or 3 years of treatment, the assessment of residual disease in a patient achieving complete remission must be performed in the bone marrow. Treatment is very effective, and only the bone marrow will provide valuable information. But in those patients achieving 3 or more years of sustained undetected MRD, we know that these patients have high chances of achieving a very long progression-free survival. And during that very long progression-free survival, we want to space out as much as possible bone marrow aspirates. We don't want to eliminate bone marrow aspirates because we know these are very important. Our mission is about to space it as much as possible to improve patient quality of life. So, for example, every 3 years, have continuous PRD assessment looking at peripheral blood and at the serum. And like I said before, not forgetting the value of imaging modalities such as PET-CT. I always end up my presentations by saying that there can be no precision medicine, individualized approaches without precision diagnostics. I do believe that among many factors that should be considered towards precision diagnostics, there will be for sure room for MRD assessment in the marrow and hopefully more and more PRD assessment in the peripheral blood. Please allow me to end my presentation by acknowledging our myeloma group at the University of Navarra in Pamplona, Spain. Also our diagnostic laboratory, the people from our diagnostic laboratory, the Euroflow consortium that is behind the development of these flow cytometry methods, and last but not least, the Spanish myeloma group. I'll stop here. Thank you for your attention.
Thank you so much, Dr. Paiva. It was so wonderful to hear what your group is doing and all of the exciting progress that's been made just in the last couple of years. So thank you so much for sharing all of that. As we discussed earlier, this is the time for some Q&A. We've already got some questions piling up in the Q&A, so we're going to do our best to group some of those together so that we can get through as many as we can in the time that we have. So if it's okay with you, Dr. Paiva, I'll just start giving you some questions and we'll get through those questions. So first question is, could you just define PRD again, just so we're all on the same page there?
Of course. By PRD, we mean peripheral residual disease. In other words, the same concept of looking for residual disease. And again, I remind everyone that looking for residual disease is about looking into a very small number of tumor cells that have persisted treatment in a patient achieving complete remission. This has been historically evaluated in the bone marrow, measurable residual disease or minimal residual disease, MRD. And more recently, when we are trying to look for these very few tumor cells in the peripheral blood, we call it peripheral residual disease or PRD.
Okay, thank you so much. Got a question just asking, is low-level MRD positivity always a bad sign? Have you seen any evidence to suggest that even patients with MRD positive after initial treatment, could there be a subset of patients who do well even when they are MRD positive?
Yeah, well, thank you for the question. It's a very important one. I'll start by saying that there isn't a perfect biomarker. And we know that while persistence of MRD is typically associated with inferior outcome, there are patients that may enjoy long progression-free survival despite positive MRD. And it is our goal and aim. Unfortunately, throughout the years, we have identified some biomarkers that can prospectively define those patients that may enjoy long progression-free survival despite a positive MRD. The evidence like phenotype, some level of immune profiling, and the absence of circulating tumor cells in the peripheral blood. These are emerging biomarkers. Now back to the question. In myeloma, differently from other hematological malignancies, usually even low levels of MRD are associated with inferior outcome.
Thank you. Got a similar question just asking about how important it is to reach MRD within 1 year of diagnosis. Can you say anything about reaching it within 2 years of diagnosis?
Yeah, well, as it would be expected, achieving an MRD negative result as soon as possible is identifying a tumor that is sensitive to that line of therapy, and hopefully because of that, the patient will live longer. This said, there are patients that achieve this optimal response with more treatment, therefore requiring more time, and most cases, achieving a late MRD negativity will produce the same benefit as an early MRD negativity. In my opinion, the earliest possible, the better. But a late MRD negativity also results in a prolonged progression-free survival.
Excellent. Thank you so much. I know with all the advancements in treatment options and just grouping the different treatment options together, it's making such a big difference in patients' life. So it's good to hear that even if they haven't reached MRD negativity initially, there's still, a lot of great options out there. So thank you. We got just a comment here. It says, "This is a brilliant presentation, and my own bout with chemotherapy and light chain amyloidosis monitored by MRD fits perfectly with what Dr. Paiva has said. I remain off treatment times 4.5 years and monitored by MRD using mass spec." So just a, shout out and a little bit of live information just showing that what you've said today is really, kind of a lived experience of one of our people listening. So thank you.
And I really appreciate this comment, and I can share with, I think it was Dr. Steven, that we have data coming out hopefully soon, also in light chain amyloidosis, and it looks as good as in myeloma in terms of redefining complete remission, which is already associated with very favorable outcome in light chain amyloidosis, and eventually also with predicting organ response, which is also a very important aspect in this disease.
Absolutely. Thank you. So we've got another question. It says, Dr. Paiva discussed MRD assessment for patients benefiting from a quadruplet combination in the first line. PFS and OS are very good. What about patients who may have already experienced 5 lines of treatment or more? Is MRD assessment worthwhile? Can PFS and OS be expected to be equally encouraging? Couple of
Well,
questions in that.
yeah, well, it's that is challenging because we know that after 5 or 6 lines of therapy, the tumor cells that are there are usually more aggressive, more resistant, and also importantly, the tumor is probably more disseminated. And even in some patients, there are chances of extramedullary disease. Because of that, while MRD negativity is a kind of prognostic value in the relapsed setting, probably its information is not that much associated with the negative result, is more about the positive result. We know that the negative result is better, but the outcome is not as good as we see in frontline, in newly diagnosed. So in my view, if there is interest in performing MRD because the patient achieved a complete remission, let's say with the 4th line of therapy, it's more about knowing if that complete remission is still associated with residual disease, in case this may help in the management, in individualizing the management of the patient. Not that much because we don't see it anymore.
Perfect. Thank you so much. Got a question just asking how drugs like Darafastpro, which are known to throw off some blood levels, how does that affect blood flow results?
Uh, I mean, the drugs per se do not affect the results of the method because these methods can be performed independently of the type of treatment. The only interaction that I mentioned before is the fact that if the patient is undergoing a very intensive treatment approach, let's say, for example, a 3 or 4 drug combination, then the blood will almost always be negative and it's less informative. So it's more, I think the application is more towards uh, uh, later stages of initial treatment or during observation if the patient is not being treated until disease progression.
Perfect. So using it more in those opportunities when patients are on like a fixed duration treatment
Yeah.
and they're off treatment there.
It's also about that stage when there are eventually more options to individualize treatment. Perhaps not that much at the beginning, rather at that middle late stage. And I think that having these kind of biomarkers there hopefully can help.
Perfect. Got a question. Of course, there's excitement around blood flow testing. So, is blood flow testing available or used in the United States yet, or is it still just in Spain?
To my knowledge, it isn't yet. You know that NGF, Next Generation Flow Cytometry, it was also born in Spain many years ago, 10 years ago, and now is everywhere, and also in many laboratories in the United States. So hopefully we can continue accumulating results, showing evidence, and this will foster the interest of other hospitals, also in the US, to perform the method.
Thank you. We've got a question just asking if this or how this might relate to smoldering myeloma. Is this something that could be used in smoldering?
Yeah, yeah. I mean, my presentation focused because that was the interest and the focus of today's webinar on assessing treatment efficacy. But the concept of circulating tumor cells is something that we are applying in all stages of the disease. We have a very large, probably the largest European project nowadays in MDES with 5,000 Spanish patients, aiming at redefining the name of MDES, eliminating the undetermined significance, because personally, I I cannot accept that in 2030, let's say, there is a condition that is diagnosed in 4 or 5% of individuals aged over 60 that is of undetermined significance. This is not acceptable, neither to the person nor the family. So must have the tools to redefine the disease and call it as no significance or clinical significance. And I think that the clinical significance, particularly in terms of malignant transformation to myeloma, light chain amyloidosis, lymphoplasmacytic lymphoma, etc., will be very much linked to the kinetics of circulating tumor cells. And in smoldering myeloma, what we aim, you know that in smoldering myeloma, there is a staging system that is the most commonly used throughout the world that is called the 2-20-20, that was defined by the International Myeloma Working Group. This is performed once, a diagnosis, and then it's never repeated
Hmm.
because no one wants another bone marrow aspirate. So at ASH, we will present another oral abstract showing that we can replace one of the 20s that stands for 20% plasma cells by a percentage of CTCs, circulating tumor cells, so that you can recalibrate the patient risk every 3, every 6 months whenever the patient returns to the consult. And because every 3, every 6 months you are recalibrating the risk, the ability of the doctor to predict the future whose patients are at risk or not of progression is much higher.
It's amazing. Thank you so much. That's exciting. I have a question that says I had testing in the beginning of September after stem cell transplant. I was told I had an M spike of 0.3 was found on SPEP, but the bone marrow biopsy was negative. How is that possible?
Well, it is. It is. I know it's unexpected and may cause some I'm missing the right word, but some confusion also to us. And this is a topic that we have investigated for many years. Again, if we were talking about relapsed myeloma, different story. But if I heard well, this is a patient with newly diagnosed myeloma that underwent autologous stem cell transplantation and probably had an assessment 3 months after the stem cell rescue. Now, it is possible in approximately 10% of patients that the immunofixation or even the electrophoresis remains positive. In other words, only the GPR and not the CR, and the MRD is negative in the marrow. Now, if MRD was negative in the marrow in a good sample without contamination with peripheral blood and using a next generation method, be it sequencing or flow, it doesn't matter, most likely this equals an MRD negative CR response and the outcome is favorable. This is almost always associated with a long half-life of the immunoglobulin. It takes more time to clear the immunoglobulin than the disappearance of myeloma cells. This is why in some patients, MRD negativity comes before the achievement of CR.
Perfect. Thank you. That was a great explanation. I appreciate that. I have a patient that says, I had 3 drug induction treatment and have been MRD negative for 5 years, along with negativity in blood and PET scans. My doctor is suggesting stopping Revlimid, which I've tolerated well if I want to. What factors should I consider in making this decision?
Well, this is let's say, a very promising disease course with a 5-year duration of response of high sensitivity. So the course is very promising. Obviously, I'll not discuss the decision because this is obviously in between this patient and her or his doctor. The point made was about risk factors of, let's say, a less robust MRD negativity, even though it is sustained for a long time, which is very, very promising. These are the presence of 2 or more high-risk cytogenetic alterations at diagnosis, an ISS 3 also diagnosis, the presence of a high percentage of circulating tumor cells at diagnosis, more than 0.01%, as well as a very late achievement of MRD negativity, which I assume it was not the case because it has been sustained for a long time. So these are the risk factors in whom we have seen together with our Italian colleagues, so reproducible findings from one group to the other, individuals having all those risk factors in whom we stopped treatment per protocol because these were two different clinical trials. The results were not that good. So these are risk factors.
Perfect. Thank you. So making sure you talk with your doctor, look through all those different risk factors, but I think that's a good summation of different things that should be considered. So thank you so much. There's a question just asking about, is there any sort of standard or any idea of how often a patient should get bone marrow biopsies if they are PRD negative and they've been PRD negative for 6 years? Like, should it be, every year, every 6 months? Is there any sort of standard yet?
So there isn't a standard yet, but I will tell you what is currently our approach based on all the data that we have generated. Part of it has been published already, part of it we are still analyzing and making those predictions. Before I share it, just to specify, for MRD assessment, you only need a bone marrow aspirate, not a biopsy. Because it sounds almost the same, but it isn't. And also from the procedure point of view, and also convenience for the patient, for MRD, you only need a bone marrow aspirate and not a biopsy. Now, and this is more like a technicality. Now, what we are seeing is that for a patient achieving, let's say, 2 or 3 years of sustained MRD negativity, this is already a patient most likely with a very favorable outcome with low risk of progression. The risk is always there, but it's low. After a 3-year sustained MRD negativity, we recommend to repeat the test in the next year. And if in the next year is negative, then in 2 years' time. And if in 2 years' time it is negative, then in 3 years' time. In other words, every year that the negative result is confirmed, you are adding 1 year spacing out those bone marrow aspirates. And this is why if we are spacing until 3 years, 4 years time, then it becomes paramount to continue monitoring the disease, let's say every 6 months in the blood and in the serum. And our expectation is that if the patient is systematically negative in the blood and serum every 6 months, then the chances that those bone marrow aspirates will continue to be negative would be very high.
Okay, thank you. And thanks for that clarification. I think coffee has not kicked in quite yet, so I appreciate that. Got a patient that says, is there a similar benefit of doing this testing after many lines of therapy? They've been 9+ years since diagnosis.
Well, that is an answer. That is a question for which I don't have, how can I say, the best possible answer. Bottom line, if a patient achieves a complete remission with whatever line of therapy, it is always positive to use more sensitive tools to really know what was the quality of that complete remission. Because the quality of the complete remission is different if there remains residual disease or, by contrast, it becomes undetectable. There is still, but we cannot detect anymore. Now, in my view, and I think the question is alluding to this, in my view, it would be ideal if we can provide an answer in the peripheral blood instead of the marrow. But to my knowledge, I think we don't have yet the data to clearly sustain what I just said. Therefore, it should be our responsibility to actively investigate and identify the treatment scenarios in the relapse setting in which MRD can be assessed in the blood and not in the marrow. Also because its value is different from the frontline setting, as I mentioned in the first question.
Okay, thank you. Trying to group some of these together, but as we talked about earlier, blood flow is not available in the U.S., but there are other blood-based assays that are available in the US. Is that correct?
Yeah, I mean, NGF that we can use in blood is already very sensitive. Is available in many laboratories. Obviously, NGS is available, particularly commercially, and you also have available, of course, mass spectrometry. And each of these methods is very sensitive. They will be informative. In my view, mm, the key is in the complementarity. So what we are suggesting is, as much as possible, if possible, I insist, to combine, for example, mass spectrometry, that is very convenient in the serum, with a cellular assessment such as NGF or NGS.
Perfect. So I got a question just about if my original bone marrow biopsy cells at diagnosis did not undergo sequencing, can I still get this type of blood testing completed? If I do need to have a current bone marrow biopsy cancer cell sequence to prepare for this testing once it's approved.
Well, that's the advantage of flow cytometry. With flow cytometry, be it NGF or blood flow, you can do it regardless of whether or not the bone marrow was studied at diagnosis. And probably this is one limitation, and then flow has a lot of other limitations, but like I said, there isn't a perfect test. So this is the key advantage of flow cytometry. By contrast, sequencing, you do need the diagnostic sample. And probably for a very high sensitive assessment using mass spectrometry, you also need the baseline serum sample.
Perfect. Thank you for that distinguishing between those. I had a question just says, I would expect quantification of MRD levels would provide answers to what direction the patient is taking. Is that so in your experience?
Yeah, I mean, and this is a question related to a previous question. The MRD levels are informative, and as one would expect, outcomes are, I would say, progressively worse the higher the MRD levels are. But the differences are not dramatic. And in my view, this is a personal opinion, the most valuable information coming from the MRD assessment is still binary, negative versus positive, much more so than the levels within MRD positivity.
Perfect. So this one's got a little bit of background, so I'm going to just read it out. It says, this more exacting assessment of PRD or MRD with blood flow may not equate with active clinical disease, given that at some point the patient's immune system and malignancy may come to a balance or homeostasis, as seen with autopsy studies of those dying of causes not related to the primary malignancy. Sorry, that was a lot to say all at once. Have you seen this, or is a consideration in using this new and brilliant technology?
Well, it's a very good question. Uh, you know, uh, and like I said, with Youngers-like phenotype, also has signatures of immune surveillance. We are trying to identify those patients in which you may have residual disease, but the outcomes uh, are favorable, and therefore you have this dissociation between the MRD result and the clinical outcome. With PRD, it's different because the presence of circulating tumor cells in the blood is really implying that the disease is proliferating again and is disseminating again from the marrow inside and out. This is a very strong indication that the risk of relapse is very high. And as you have seen in the slides, the time until disease progression is usually only a few months. So it's quite the contrary. And I'll repeat what I said before. If the patient is MRD positive in the marrow, looking at the blood will inform if that positive MRD is linked to very high risk of relapse because of positive in the blood, or by contrast, lower risk of relapse because the blood is negative.
Perfect. And this one kind of falls into that same line, just asking, would PRD positivity alone make you want to add additional medications to maintenance treatment? So that sounds like they're asking about, potential of relapse. Does that sound correct?
Well, I think the question is, if I was negative before and now I'm positive,
Mhm.
be it in marrow or blood, should this be an indication to resume treatment? I think that's a very valuable, important question for which there isn't an answer yet because of lack of data that is being accumulated in many, many ongoing clinical trials. We just need to wait for the readout of those trials.
Perfect. Thank you so much. Got several people just thanking you so much for your time today. It's morning for us, of course. It's getting to be evening for you. So just want to thank you for your time and for all of the wonderful information you shared today. Lots of people saying thank you so much.
Thank you for all that you do. And it is my pleasure. And hopefully we can meet soon again and repeat as much as possible this webinar.
Absolutely. Thank you so much.
Thank you. Have
With
a good,
that, oh, sorry, go ahead.
no, thank you. Have a good day.
Thank you too. With that, we will go ahead and wrap up today's session. Thank you all for joining. Again, we will have the recording available and just want to say thank you again. So, as a note, just make sure you take that quick survey about your experience today. And I just wanted to highlight a few of our upcoming events. So, tomorrow, Tuesday the 7th, at 1 p.m. Eastern, we'll have our bi-monthly blood cancer financial Q&A where you can get expert answers to treatment cost and support questions. When you register for the event, you'll have the opportunity to pre-submit questions, and we will answer those live. We'll also have some time for a Q&A at the end. So if anything comes up during the webinar, make sure you jot those questions down and we will get those questions answered. Then this Saturday, October 11th, we'll be hosting one of our Connect to Cures events. If you are in or around Brooklyn, New York, consider joining us for a wonderful event that's meant to connect you with other patients and resources in your community. I'll talk more about our Connect to Cures program on the next slide. And then this following Thursday, October 16th, our Hispanic Myeloma Health Group will have the opportunity to hear from fellow myeloma patient and coach Susana Vivares as she talks through her experience with stem cell transplant. Please take note that this is for our Spanish speakers. If you're interested in registering for this or any of our events, please check out our registration page through healthtree.org. I'll also send the link to sign up in the follow-up email. I wanted to highlight an exciting opportunity, as I said in the previous slide. These are our Connect to Cures events. We've got just a few more opportunities for the remainder of the year, and we've already started building out our schedule for next year. So if you are in any of the cities on the screen and would like to participate, volunteer, hand out flyers, or just come and enjoy the program, we would love to see you. There's a QR code on the screen, and I'll also include this in our follow-up email. But again, these Connect Cure programs are in person and are free to anyone who'd like to join. I'd like to again thank our sponsors, Adaptive, Pfizer, Johnson & Johnson, Amgen, and GSK. And lastly, I've got my email address up on the screen. I really do love hearing from you guys. So if you would like to send me an email, that's my email address. And I truly appreciate you all and hope you have a wonderful rest of your day.